Reassessment and follow-up expand through the implementation phase of case management with the client. The implementing phase centers on the execution of the specific case management activities and interventions that are necessary for accomplishing the goals set forth in the client's case management plan. This is commonly known as care coordination. During this phase, the case manager organizes, secures, integrates, and modifies, as needed, the behavioral health services and resources necessary to meet the client's needs and interests. The case manager also shares key information on an ongoing basis with the client and the client support system, and with healthcare providers and clinicians that are collaborating with the client and the case manager. The case manager may also collaborate with the health insurance company and representatives of the community-based agencies that are engaged and will be engaged in the client's care and case management plan. The bulk of case management work occurs in the implementation of the service plan. Service plan implementation involves carrying out tasks listed in the plan, including the following activities: provider contact in person, by phone, and in writing; assistance to the client and the collaterals in applications for services and entitlements; assistance in arranging for services, making appointments, confirming service delivery dates; encouragement to the client and the client support system to carry out the tasks they agreed to; direct education to the client and the client's collaterals as needed; support to enable the client and the client support system to overcome the barriers that were identified and access services; negotiation and advocacy as needed; other case management activities as needed by the client and as expected and permissible by the program's initiative. In general, the type and frequency of contact should be based on the client's needs. Client contact and monitoring are expected to be frequent and proactive in order to anticipate problems, stabilize the client's status, prevent crises, and support the client in achieving service goals. Expectations include face-to-face contacts, home visits, and accompanying the client to providers where necessary to ensure that the service is made. Client contact and monitoring is required to follow up on referrals, to determine the status of service acquisition, and to assess whether the client has further needs requiring additional case management services. This reassessment process is an ongoing process that engages the client and the provider to ensure that the client's goals are current, that effective and efficient movement towards achieving the client's goals is occurring, and that the client and the providers are satisfied with the process and the outcomes. Getting reports from schools, therapists, psychiatrists, guardian ad litems, family members, and other agencies or other active participants in the client's treatment is also a part of this reassessment process. You will then analyze these reports, perhaps with your supervisor, or you might call a staffing to review the client's progress with agency providers. You will conduct outcome measures per Florida state requirements, which track the functioning of the client over the course of treatment. Outcomes allow the case management service effectiveness to our clients. Outcomes are completed by the agency, and you will want to check with your supervisor on how case managers take the lead in completing outcomes for clinical programs and collaborate with the clinical program providers to be able to make the assessment. You will be taking the training to become a FARS or CFARS rater, but let's take a minute to remember that the FARS and CFARS are completed at the time of the very first service, and then every 6 months, and when a significant change occurs or at discharge. Mental health outcomes, on the other hand, are completed also at the time of first service, but every 3 months, and then again at the time of discharge. Substance abuse outcomes are completed at the time of the first service and at discharge. And while we're trying to keep track of when documentation is due, we also want to keep track of the recovery process the client is going through in this process of following the service plan to obtain their goals and objectives. Recovery is not a solitary process or a journey that one takes alone. It's fundamentally a social process. In the social process, individuals become interdependent in a community where they can both share in their disappointments and pain and revel in their joy and successes with others. People in recovery often describe the importance of having someone believe in them when they could no longer believe in themselves, and often attribute their recovery, more than anything else, to someone really believing in me or seeing something inside of me that I couldn't see. As the client continues to work on the service plan and the objectives are being accomplished towards the service goals, the implementation phase centers on the execution of specific case management activities that are necessary in accomplishing the goals set forward in the client's case plan. This is commonly known as care coordination. During this phase, the case manager secures, integrates, and modifies behavioral health resources necessary to meet the client's needs and interests. The case manager also shares ongoing information about the client with the client and with the client support system, healthcare providers, clinicians, and others that may be collaborating. Convey to providers that the case manager is there to assist them in facilitating their orders and treatment, and to be supportive for all stakeholders in order to achieve the optimum outcome for the client. It is vital that there is good communication between all those involved in the client's care. Evidence-based quality outcome data needs to be the basis for this communication. Case management is most effective when it works alongside other strategies that support greater integration and coordination of care for the client. This integration and collaboration with health providers and clinical providers allows the group to work together to support the development of shared objectives and to enable delivery of joint services to the client who may have complex needs. Access to community-based services such as diagnostics and other treatment is essential to ensure that care can be delivered in a timely manner. But again, that is yet another thing case managers do day in and day out without missing a beat. Here's a quote from Lou Holtz that seems to describe aspects of case management. "I follow these 3 rules. Do the right thing, do the best you can, and always show people you care. You've got to make a sincere attempt to have the right goals to begin with, then go after them with appropriate effort, and remember, you can't really achieve anything without the help of others." This diagram will give you the context for how you are reassessing service delivery with the client, frequently through the course of a month or several months. Start at the left-hand side. Documentation provides evidence of the assessment being made of the client's progress towards service plan goals and objectives being accomplished. Review the stated objectives with the client at face-to-face meetings, and with the client, identify how the client's strengths are helping he or she to achieve those steps. Determine, too, if the expected barriers are being alleviated and if new barriers have developed. Following the arrows in this diagram, we might determine that the next setting or appointment that we might want to negotiate or modify the service plan depending on the client's ease in achieving objectives. If the plan is modified, the case manager will want to review the problem list with the client to evaluate current problems and establish or modify the goals and objectives. Determine with the client if support systems need to be contacted and updated on these changes. Set a next appointment. The case manager documents clearly and concisely the conversation that took place, the evaluation of progress towards goals, and the client's estimation of progress. The service plan review is a process conducted to ensure that services, goals, and objectives continue to be appropriate to the client's needs and to assess the client's progress and continued need for case management services. The client's eligibility for continued case management services must be reevaluated during the service plan review. The activities, discussion, and review process must be clearly documented. The client's parent or guardian, legal guardian, supportive others, the targeted case manager, and the supervisor, the targeted case management supervisor, must sign and date the service plan review. The service plan must be reviewed and revised no less than every 6 months. Documentation of the service plan review must be recorded in the client's record. When the client completes the service plan, having attained all the objectives and goals, there may be a discussion about a transition to another level of care or discharge. This transition phase focuses on moving the client across the behavioral health services continuum to a level of care that meets medical necessity. During this phase, the case manager prepares the client and the client support system for either discharge or for the other level of care. Transition and discharge plans should be included on the updated service plan. Documentation tells the client's story. Case notes should clearly show the client's progress towards his or her goals at a level of detail such that any other case manager or provider would be able to understand the client's situation and the services received without additional documentation. Thorough notes include data on the client's eligibility as well as the services received, the outcomes of those services, and the results of both formal and informal conversations. Documentation should include detailed but concise information gathered directly from the client, or in some cases from the client's social system. For example, if the case manager has been unable to contact a client but learns that the client is employed through an informal conversation with a family member, that should be documented. These notes should also include the case manager's observation of a client's behavior and descriptions of situations that indicate the existence of a challenge that the client has not disclosed. Case notes also serve as a critical record of accountability for both the case manager and the client. As such, they should include specific action items for both the case manager and the client, as well as a timeline for completing those items. When a client makes progress or reaches a goal, the case manager should record this, and the individual treatment plan or service plan should be reviewed and updated. Electronic case records can facilitate the creation of more precise case notes and more comprehensive tracking of a client's progress and services across multiple programs. What is the best way to follow up with folks? Let's take a look at some research into case manager follow-ups to failed appointments and subsequent service utilization. Case manager responses to failed appointments were monitored for 83 seriously mentally ill persons in a rural community mental health center. Case manager actions taken were grouped into 4 categories of follow-up, from most intensive to least intensive: home visit, phone call, letter, or no follow-up. On the whole, case managers most frequently did not follow up, missed appointments, and that was at 56.7%. Case managers followed up by letters 21% of the time, and with telephone calls 18.7% of the time, and with home visits only 3.3% of the time. An analysis revealed that home visits were most intensive, and all clients who were visited following failed appointments did not fail subsequent appointments. Let me say that again. Home visits are intensive, and all clients who were visited following failed appointments did not fail the subsequent appointments. Clients who received telephone calls or letters were about equally likely to fail the subsequent appointment, but were much more likely to attend the subsequent appointment than were clients who received no follow-up to the failed appointment. Interestingly, clients who failed appointments and received no follow-up were much more likely to need emergency services rather than a regular appointment as their next contact with the clinic. This ends the training for reassessment and follow-up. Please take the test for this lesson. A passing score is 70%.